Somewhere right now, a woman is sitting in a waiting room for the fourth specialist this year. She has already been told it is fibromyalgia. She has already been told it might be early Ms. Someone even floated rheumatoid arthritis before the blood work came back inconclusive. Nobody has said the word Sjogrens out loud yet. And that is exactly the problem I want to unravel with you today, because there are 5 things, only 5, that quietly separate Sjogrens from fibromyalgia, from IA, and from Ms. Most doctors are not trained to look for all 5 at once. Most patients never hear them explained together in one place. By the end of this video you will know things about your own body that took other women years and a stack of normal test results to figure out the hard way. I built something specifically not for just tracking and doctor's appointment. It is called Sjogrens Ultimate Symptom Map and Diagnostic Action Plan, and it walks you through exactly which symptoms to track not just for Sjogren but also for MS and RI. Drop symptom map in the comment, and I would send the link for you to access it. I want you to think of this less like a lecture and more like a case file. I am someone who reads the research obsessively, who talks to patients constantly, who has spent an unreasonable number of nights cross-referencing symptom clusters because the overlap between these 4 conditions is not an accident. It is a trap. It is what I call the sicker gap, the space between what a normal exam can catch and what an autoimmune disease is actually doing to your body while everyone is looking somewhere else. If any part of this sounds like your own story, comment the word blocked below, because that one word tells me you have been stuck in this exact loop, dismissed, misdiagnosed, or told it is all just stress. Let's set the scene properly first, because you cannot understand why these 4 conditions get confused unless you understand how similar they look from the outside. Fibromyalgia gives you widespread pain and exhaustion that will not respond to normal treatment. Rheumatoid arthritis gives you joint pain, stiffness, and swelling that seems to migrate. Multiple sclerosis gives you strange neurological symptoms that come and go, numbness, tingling, vision changes, fatigue that flattens you without warning. And Sjogrens, quietly, gives you a mix of all 3, plus something almost none of the others explain well, and that is the dryness that never gets discussed as a systemic disease symptom. Dry eyes get blamed on screens. Dry mouth gets blamed on medication or dehydration. Nobody connects it to the rest of the picture, and that disconnect is the first crack in the case. Here is the part that should make you sit up. Sjogrens is not rare. It affects an estimated 4 million people, and yet it takes an average of years, not months, years, to get an actual diagnosis. During that stretch of time, most women get handed one of the other 3 labels first. Fibromyalgia becomes the default when blood work looks borderline. IA becomes the guess when joints ache without visible swelling yet. MS gets floated the moment neurological symptoms show up on an MRI referral. And through all of that, the 5 things I am about to walk you through get overlooked, because none of them show up on a single standard test. You have to know to look for the combination. Thing number 1 is the dryness pattern, but not the way you are picturing it. Everyone assumes dry eyes and dry mouth are surface-level annoyances. In Sjogrens, they are the visible tip of something happening at a glandular and immune level throughout the entire body. Your immune system is attacking the moisture-producing glands, yes, the ones in your eyes and mouth, but also glands lining your gut, your skin, your vaginal tissue, your sinuses. That is why the dryness in Sjogrens rarely stays isolated. It spreads. Dry eyes that burn and feel gritty in the morning. A mouth so dry you wake up needing water in the middle of the night, every night, for months. Skin that stopped sweating properly even in heat. A dry cough that no inhaler touches because it is not asthma, it is dry airway tissue. None of the other 3 conditions produce this exact multi-system dryness pattern. Fibromyalgia does not touch your tear glands. IA does not dry out your gut lining. MS does not typically leave your mouth feeling like sandpaper for years on end. When dryness shows up everywhere at once, not just your eyes when you are tired, that is clue 1, and it is the clue doctors are least likely to ask about directly because sicker symptoms get treated as minor and cosmetic instead of systemic and diagnostic. If you just felt a small jolt of recognition, hold on to it, because thing number 2 builds directly on top of it, and this is where the case really starts to separate itself from fibromyalgia specifically. Thing number 2 is the fatigue signature, and I want to be precise here because fatigue alone means nothing. Every single one of these 4 conditions causes fatigue. That is exactly why fatigue is useless as a standalone clue. What matters is the shape of the fatigue, the way it rises and falls, the way your body responds when you rest. Fibromyalgia fatigue tends to be constant, a baseline exhaustion that barely lifts even with a full night of sleep, layered with pain that makes rest itself uncomfortable. Sjogren's fatigue behaves differently. It often comes in waves tied to inflammation flares, meaning you can have stretches of relatively normal energy followed by sudden crashes that feel almost viral, flu-like exhaustion with no fever, no infection, nothing that shows up on a basic panel. Patients describe it as hitting a wall mid-afternoon regardless of how much they slept the night before. This wave pattern lines up with something measurable, inflammatory markers rising and falling in blood work over time, something fibromyalgia typically does not show because fibromyalgia is not classified as an inflammatory or autoimmune disease at all. That distinction alone should stop any doctor from treating these two conditions as interchangeable, and yet it happens constantly because both produce pain plus fatigue plus a normal-seeming physical exam. The difference is that Sjogren's fatigue has an inflammatory fingerprint underneath it, even when standard blood work comes back looking deceptively clean on the surface. I want to pause here and name something directly, because I think it needs to be said plainly instead of dressed up. The reason so many women get told it is fibromyalgia first is because fibromyalgia has become the diagnosis of exclusion, the label doctors reach for when nothing else fits cleanly and further testing feels expensive or time-consuming. That is not a criticism of any single doctor, it is a structural problem in how autoimmune disease gets investigated. Antibody panels for Sjogren's are not part of a routine workup. They have to be specifically requested, and they often have to be requested more than once, because early Sjogren's can produce negative antibody results even while glandular damage is actively happening. This is one of the most under-discussed facts in the entire conversation around this disease. A negative antibody test does not rule out Sjogren's. It just means the disease has not yet produced enough antibody activity to register, or that the specific antibodies being tested are not the ones your immune system happens to be producing. If you have been told your blood work is normal so it cannot be Sjogren's, comment the word file, because that phrase, blood work is normal, is exactly how the sicker gap swallows patients whole for years at a time. Thing number 3 moves us into joint territory, which is where the confusion with rheumatoid arthritis becomes almost identical on the surface and only separates itself once you know exactly what to look for. Sjogren's frequently causes joint pain and stiffness, especially in the morning, especially in the small joints of the hands, wrists, and knees. On paper, that description matches IA almost word for word. Here is the separation. In classic IA, joint damage tends to be erosive, meaning over time imaging will show actual physical erosion and deformity in the joints if the disease goes untreated, and inflammatory markers plus specific antibodies, rheumatoid factor, and anti-CCP, are frequently elevated together in a pattern that is fairly consistent. In Sjogren's related joint pain, the pain and stiffness can be just as real, just as disruptive, but imaging often stays clean far longer, sometimes indefinitely, because the joint involvement tends to be non-erosive. Your joints hurt, they feel swollen and stiff especially first thing in the morning, but scans do not show the same progressive structural damage that classic RA produces. This is a genuinely confusing overlap because some patients do carry positive rheumatoid factor without having RA at all, and some Sjogren's patients are misdiagnosed with RA for years before anyone checks for the dryness pattern from clue 1 alongside the joint symptoms. The tell is combination, not isolation. Joint pain by itself proves nothing. Joint pain plus non-erosive imaging plus the systemic dryness pattern plus that wave-shaped inflammatory fatigue starts building a picture no single condition on its own fully explains. This is usually the point in the case where things get tangled, and I mean that specifically, because tangled is the word patients use over and over to describe what it feels like when 3 or 4 labels are all half true at once. If that word landed for you, comment tangled, because that is the exact sensation of being caught between diagnoses that all fit partially and none fit completely. Thing number 4 is where the comparison with multiple sclerosis becomes unavoidable, and this is honestly the clue that scares people the most, because it involves the nervous system, and nothing feels more destabilizing than neurological symptoms nobody can immediately explain. Sjogren's is capable of affecting the nervous system directly. This surprises almost everyone, including some doctors who think of Sjogren's purely as a dryness disease. It can cause peripheral neuropathy, that tingling, burning, numb sensation typically in the hands and feet. It can cause small fiber neuropathy specifically, which frequently does not show up on standard nerve conduction studies, meaning a patient can have very real nerve damage and still be told their neuro workup looks normal. In rarer but documented cases, Sjogrens can produce central nervous system symptoms that mimic MS closely enough that MRI findings have been misread as multiple sclerosis before the correct autoimmune driver was identified. This is not a fringe theory, this is a recognized diagnostic challenge discussed in rheumatology and neurology literature, because both conditions can produce white matter changes on brain imaging, both can cause sensory disturbances that wax and wane, both can produce fatigue that suddenly flattens a person who was fine the day before. The separating detail tends to be pattern and company. MS lesions typically follow a more classic distribution pattern in the central nervous system and are frequently accompanied by distinct neurological deficits that build a specific type of clinical picture over time. Sjogren's-related neurological symptoms are far more likely to travel alongside the dryness, the joint pain, and the wave fatigue from clues 1 through 3, rather than existing on their own in isolation. Neurological symptoms without the Sika pattern lean the picture toward MS. Neurological symptoms tangled together with dryness, joint pain, and inflammatory fatigue lean the picture hard toward Sjogren's. This is precisely the kind of nuance that gets lost when a patient is sent straight to a neurologist without anyone connecting the dots back to the dryness they mentioned in passing 2 appointments ago. I need to say something here because I think it matters more than any single fact in this video. If you are currently living inside unexplained neurological symptoms and you are frightened, that fear is completely reasonable, and it does not mean you are overreacting. It means your body is sending signals that deserve a full, connected investigation, not a series of disconnected specialist visits that each only look at one piece of you. This is not something to sit with alone hoping it resolves itself. If any part of what I have described feels uncomfortably close to your own experience, please bring this exact list, all 5 things, into your next appointment and ask directly whether Sjogren's antibody testing and a lip biopsy have ever been considered as part of your workup. Thing number 5 is the one almost nobody talks about, and it might be the single most overlooked piece of this entire puzzle, because it lives outside the categories doctors are trained to search first. It is autonomic nervous system involvement. Your autonomic nervous system runs everything you never consciously think about: heart rate, blood pressure regulation, digestion, temperature control, the ability to stand up without your vision going dark. Sjogren's has a well-documented but under-discussed relationship with autonomic dysfunction, sometimes showing up as a rapid heart rate on standing, sometimes as digestive symptoms that mimic irritable bowel disease, sometimes as an inability to regulate body temperature properly, feeling either too hot or too cold when the room temperature has not changed at all. Fibromyalgia can produce some autonomic symptoms too, which is part of why the overlap persists, but the mechanism is different, and when autonomic symptoms show up specifically alongside glandular dryness, they point far more strongly toward an autoimmune driver like Sjogren's than toward a central sensitization disorder like fibromyalgia. I rarely touches the autonomic system directly at all. MS can affect it in later stages, but typically after a clearer neurological disease course has already established itself. When a patient describes dizziness on standing, digestive chaos, temperature regulation problems, and dry eyes and mouth all in the same breath, that combination should trigger Sjogren's-specific testing immediately. In practice, it almost never does, because each symptom gets sent to a different specialist who only evaluates their own organ system, and nobody in the chain is asking the one question that would tie it all together, which is simply this: does all of this happen alongside dryness that never gets better? So here is the full case laid out together, the way it should have been explained to you the very first time a doctor heard more than one of these symptoms in the same sentence. Clue 1. Systemic dryness that spreads beyond eyes and mouth into skin, airways, and gut. Clue 2. Wave-shaped inflammatory fatigue rather than the constant flat exhaustion typical of fibromyalgia. Clue 3. Non-erosive joint pain that mimics RA on the surface but behaves differently on imaging over time. Clue 4. Neurological symptoms that travel in company with the other clues rather than standing alone the way classic MS symptoms typically do. Clue 5. Autonomic nervous system dysfunction, the most overlooked signal of all, showing up as heart rate changes, digestive chaos, or temperature regulation problems laid on top of everything else. Individually, every single one of these 5 things can be explained away by something else. That is exactly why this disease hides so well and for so long. Together, in combination, they tell a story that only Sjogren's fully accounts for. I want to be honest about something before we go further. None of this replaces proper testing, and I am not diagnosing you. I could never do that, and neither should any video. What I am doing is handing you language, the specific language that tends to get results when you say it out loud to a doctor, because vague statements like I am always tired and everything hurts get treated very differently than a patient walking in and saying, I have dryness across my eyes, mouth, and skin, wave pattern fatigue tied to what feels like inflammation, joint stiffness that has not shown erosive damage on imaging, neurological symptoms alongside the dryness, and autonomic symptoms, like rapid heart rate on standing. That second version is specific enough to justify a referral for antibody testing, a Sjogrens test for tear production, and potentially a lip biopsy, which remains one of the most definitive ways to confirm glandular involvement in Sjogrens even when antibody panels come back negative. I built something specifically for this moment, the moment right after watching a video like this one where 5 separate symptoms suddenly feel like they belong to the same story instead of 5 unrelated complaints. It is called the symptom map, the full diagnostic action plan that lays out exactly how Sjogrens separates itself from fibromyalgia, RA, and MS, along with the specific tests to request and the language to use so you are taken seriously the first time instead of the fourth. If you want it, comment the word map below and I will make sure you get the link. Let's go back to that woman in the waiting room for a moment, because I think about her a lot while writing these scripts. She has already collected 3 labels that do not quite fit. Fibromyalgia because her blood work looked borderline. A tentative mention of early RA because her hands ache in the morning. A referral to neurology because of tingling in her feet that nobody could explain. What she has not been asked, in any of those appointments, is whether her eyes feel gritty by mid-afternoon, whether she needs water beside her bed every single night, whether standing up too fast makes the room tilt sideways for a few seconds. Nobody connected clue 1 to clue 5 because nobody in that chain of appointments was looking at the whole pattern at once. That disconnect, more than any single missed test, is the actual reason Sjogrens takes years to diagnose. It is not that the evidence is not there. It is that the evidence is scattered across 4 different specialists, who each only see their own slice of it. I want to walk through a slightly deeper layer now, because I think you deserve more than a surface pass on why these 4 conditions get tangled together so consistently in the medical system, and understanding the why makes it much easier to advocate for yourself with confidence instead of anxiety. Fibromyalgia is currently understood as a central sensitization disorder, meaning the nervous system itself becomes hypersensitive to pain signals, amplifying normal sensations into something far more intense and widespread. It is a real and serious condition, but it is not classified as autoimmune or inflammatory in the traditional sense, which is precisely why standard inflammatory blood markers usually stay normal in fibromyalgia even during a bad flare. This is actually one of the clearest separating details available, and it is rarely explained to patients directly. If your inflammatory markers, things like ESR or CRP, come back consistently elevated alongside widespread pain and fatigue, that elevation itself is a signal pointing away from fibromyalgia and towards something inflammatory or autoimmune driving the picture instead, Sjogrens very much included. Rheumatoid arthritis, by contrast, is clearly autoimmune and clearly inflammatory, and it frequently does show elevated markers, which is part of why it gets confused with Sjogrens more easily than fibromyalgia does. The separating detail here leans more heavily on imaging over time and antibody specificity. Rheumatoid factor can appear in Sjogrens patients too, which is exactly why relying on that single antibody alone is not enough. The more specific antibodies associated with Sjogrens, along with the pattern of non-erosive joint involvement over years rather than progressive erosive damage, tend to be the details that eventually separate the 2 conditions when a rheumatologist takes the time to look closely. Multiple sclerosis sits in its own category because it is a demyelinating disease of the central nervous system specifically, meaning it attacks the protective coating around nerve fibers in the brain and spinal cord. Sjogrens, when it affects the nervous system, can sometimes cause a demyelinating picture as well, which is exactly why the 2 get confused on imaging in complicated cases. The distinguishing detail tends to come down to the broader clinical picture, not any single scan. A neurologist looking only at an MRI showing white matter changes might reasonably suspect MS. A rheumatologist who also knows about the dryness, the joint symptoms, and the autonomic issues has a much stronger case for ordering Sjogren-specific antibody testing before settling on an MS diagnosis. This is exactly why multidisciplinary communication matters so much, and exactly why it so often fails, because these specialists rarely compare notes on the same patient in real time. I think it is worth naming plainly that this entire situation, the years-long path to diagnosis, the scattered specialists, the negative tests that do not actually rule anything out, takes a real toll that goes beyond the physical symptoms themselves. Living for years without a name for what is happening to your body is exhausting in a way that is hard to explain to anyone who has not lived through it. If you are in the middle of that right now, I want you to know that the confusion you are experiencing is not a personal failure and it is not in your head. It is a structural gap in how these 4 conditions get investigated, and naming that gap is the first step toward closing it for yourself. Let's talk about what actually helps once Sjogren's specific testing is on the table, because knowing the 5 clues is only useful if it leads somewhere actionable. The first step is usually specific antibody testing, commonly the anti-SSA and anti-SSB antibodies, sometimes labeled anti-Rho and anti-Lane. These come back positive in a majority of confirmed Sjogren's cases, but importantly, not all, which loops back to why a negative result should never be treated as the final word. The second step, when antibody results are unclear or negative despite strong clinical suspicion, is a minor salivary gland biopsy, typically taken from the inner lip, which can reveal the specific inflammatory cell patterns characteristic of Sjogren's even when blood work looks clean. The third step is objective dryness testing, a Sjogren's test measuring actual tear production, or staining tests that reveal surface damage on the eye that patients cannot always feel directly yet. None of these tests are exotic or unavailable, they simply are not ordered automatically, which means the responsibility often falls on the patient to specifically request them by name. This is exactly why language matters so much in that appointment room. Walking in and saying my eyes feel dry sometimes invites a recommendation for over-the-counter eye drops and nothing further. Walking in and saying I have dry eyes and mouth that have persisted for months, alongside joint pain, fatigue that comes in waves, and some nervous system symptoms, and I would like to be tested for Sjogren specifically, including antibody testing and a possible lip biopsy, changes the entire trajectory of that conversation. You are not being dramatic by using specific language. You are closing the exact gap that keeps this disease hidden for years at a time. I also want to address something that comes up constantly in comments on videos like this one, the fear of being the difficult patient, the person who walks in with a list and a theory and worries about being dismissed for it. Here is the honest truth. A patient who arrives with specific, organized information makes a doctor's job easier, not harder, because it gives them a clear starting point for investigation instead of a vague complaint to sort through blind. You are not being difficult by naming 5 specific patterns you have noticed in your own body. You are doing the diagnostic groundwork that too often gets skipped entirely in a 15-minute appointment. Let's circle back one more time to the elimination process, because I think laying it out as a sequence, rather than 5 scattered facts, makes it far easier to hold on to and use. Start with fibromyalgia. If your inflammatory markers are consistently elevated and your dryness is systemic rather than occasional, fibromyalgia alone becomes a weaker fit, because fibromyalgia does not typically produce either of those 2 things. Move to IA. If your joint pain persists for years without erosive changes on imaging, and rheumatoid factor is either negative or accompanied by more Sjogren-specific antibodies, classic IA becomes a weaker fit as the sole explanation. Move to MIS. If your neurological symptoms consistently travel alongside dryness, joint symptoms, and autonomic dysfunction rather than appearing in isolation with a more classic MS pattern, MS alone becomes a weaker fit. What remains, once each of the other 3 explanations weakens under the weight of the full pattern, is a condition that explains dryness, wave fatigue, non-erosive joint pain, connected neurological symptoms, and autonomic dysfunction all at once, under a single diagnostic umbrella. That is Sjogren's, and that is exactly why it deserves to be tested for directly instead of arrived at last, after every other label has already been tried and found incomplete. Before we close this out, I want to say one more thing directly to whoever is watching this because the message applies to them specifically and not to the abstract idea of a viewer. If you have felt unheard across multiple appointments, if you have been told your labs look normal while your body keeps insisting otherwise, if you have started to quietly wonder whether you are exaggerating your own symptoms because nobody has connected the dots yet, none of that means you are wrong about your own body. It means the investigation has not been thorough enough yet, and thoroughness is something you are allowed to advocate for. You know your own baseline better than any single specialist glancing at one test result in isolation. If this video helped you see your own pattern more clearly, the most useful next step is the symptom map, built specifically to walk you through these same 5 clues in a format you can bring directly into your next appointment, along with the exact tests to request by name so you are not relying on memory alone in a rushed 15-minute visit. Comment the word map and I will get it to you. And if you know someone else stuck in this exact loop, someone collecting labels that almost fit but never quite land, send this video to them. Because sometimes the only thing standing between someone and a real diagnosis is finally hearing all 5 clues explained together in one place instead of scattered across 4 different waiting rooms over the course of several years. I want to stay with this a little longer, because I know some of you are not watching this out of curiosity, you are watching it because you are somewhere in the middle of this exact confusion right now, and a short wrap-up would not do that justice. So let's slow down and go back through each of the 5 things one more time. This time with the kind of granular detail that actually helps you notice these patterns in your own daily life instead of just recognizing them intellectually while you watch. Start with the dryness pattern again, because I think it deserves a second, closer pass. Most people picture dry eyes as a mild irritation, something that happens after a long day of screen time. Sjogren's dryness behaves differently in a few specific ways that are worth naming out loud. It tends to be worse in the morning, because tear production slows further during sleep. So waking up with eyes that feel glued shut or gritty, needing a moment before you can open them comfortably, is a much stronger signal than dryness that shows up only after hours of reading or scrolling. It tends to be accompanied by a foreign body sensation, the feeling that there is something in your eye even when there is nothing there, a sandy or gritty texture that artificial tears help only temporarily. On the mouth side, the clue is not just feeling thirsty, it is the specific experience of dry crackers or bread sticking to the roof of your mouth, needing liquid to swallow food that would normally go down easily, waking up at 2 in the morning needing water, sometimes more than once a night, for months at a stretch. Dentists sometimes catch this before doctors do, because chronic dry mouth accelerates dental decay and gum problems in a pattern that is recognizable to anyone trained to look for it. So if you have had an unusual uptick in cavities or gum issues in recent years alongside these other symptoms, that is worth mentioning specifically at your next appointment. The skin dryness piece gets overlooked constantly because it is easy to blame on weather, on aging, on soap, on anything except the actual underlying cause. Sjogren's related skin dryness tends to be persistent regardless of moisturizer use, sometimes accompanied by reduced sweating in a way that makes heat regulation genuinely difficult, not just uncomfortable in the way normal heat sensitivity feels. Some patients describe feeling like their body simply stopped sweating properly in situations where it obviously should. At the gym, in direct sun, during a fever. That specific detail, reduced or absent sweating alongside dry skin, is far more diagnostically useful than dry skin alone, because plenty of things cause dry skin and almost nothing besides glandular dysfunction causes both dry skin and impaired sweating together. Now let's go deeper on the fatigue signature, because I think the wave pattern deserves more texture than a single description can give it. Picture your energy on a normal week without any inflammatory disease. It dips a little in the afternoon, it responds to sleep, it responds to caffeine, it behaves the way energy is supposed to behave. Now picture a week where, without any clear trigger, without a bad night of sleep, without a stressful event, you suddenly hit a wall around midday that feels almost like the onset of the flu, heavy limbs, a kind of mental fog that makes normal conversation feel effortful, a bone-deep tiredness that no amount of caffeine touches. That crash can last for a few hours or it can last for days. And then, just as unpredictably, it lifts, and you have a stretch of days where you feel almost like yourself again. This wave pattern, crash then partial recovery then crash again, without a clean external trigger each time, lines up with inflammatory flares in a way that flat, constant fatigue simply does not. If you have ever described your own fatigue to a friend as coming out of nowhere, as feeling like you caught a virus that never actually arrived, that specific language, coming out of nowhere, flu-like without a fever, is worth repeating word for word to a doctor, because it points toward an inflammatory process working underneath the surface rather than a purely central nervous system pain amplification process. On the joint pain front, I want to add one more layer of nuance, because the words stiffness and pain get used almost interchangeably by patients even though they mean different things clinically, and that distinction matters here. Stiffness refers specifically to a reduced range of motion, a difficulty bending or straightening a joint fully, especially first thing in the morning, often improving somewhat with movement over the following half hour to an hour. Pain refers to the sensation itself, aching, sharp, burning, whatever form it takes. Sjogren's related joint involvement frequently produces significant morning stiffness that improves with movement, alongside pain that can flare unpredictably, but without the same degree of visible swelling and eventual joint deformity that untreated RA typically produces over years. If your joints hurt and feel stiff but a rheumatologist examining them directly does not find significant swelling, and repeated imaging over time does not show progressive erosion, that combination, real symptoms plus a relatively unremarkable physical exam plus clean imaging over time, is exactly the pattern that gets patients told their joint pain is not serious, when in fact it may simply not be RA, and may instead be part of a broader Sjogren's picture that deserves its own specific investigation. On the neurological symptoms, I want to be careful and thorough here because this is the piece that generates the most fear, understandably, and fear deserves precision rather than vague reassurance. Peripheral neuropathy in Sjogren's often starts subtly, a tingling or slight numbness in the toes or fingertips that comes and goes, sometimes dismissed as sitting wrong or sleeping on an arm awkwardly, until it becomes more persistent and starts appearing without any positional explanation at all. Small fiber neuropathy specifically can produce a burning sensation, especially at night, in the feet or hands, and this is the type of nerve damage that standard nerve conduction studies frequently miss entirely, because those studies are built to detect large fiber damage, not small fiber damage. This is an incredibly important detail that rarely gets explained to patients directly. Being told your nerve conduction study is normal does not mean your nerves are fine. It means the specific type of nerve fiber that test measures is functioning normally, while an entirely different category of nerve fiber can still be damaged and undetected by that particular test. If small fiber neuropathy is suspected, a skin punch biopsy can sometimes detect it where nerve conduction studies cannot, and this is worth asking about by name if you have persistent burning or tingling sensations that have been called normal based on a nerve conduction study alone. On the central nervous system side, the overlap with MS deserves one more layer of nuance too. When Sjogren's does affect the central nervous system, the resulting white matter changes on MRI can sometimes closely resemble the lesions seen in MS, which is precisely why some patients carry an MS diagnosis for years before Sjogren's specific testing reveals the actual underlying driver, and why in some documented cases the reverse happens. Patients are initially suspected of having Sjogren's related neurological involvement before a more classic MS pattern eventually clarifies itself. This is not a simple one-directional confusion, it runs both ways, which is exactly why the full symptom picture, not the imaging alone, has to guide the next diagnostic step. A neurologist who only sees the scan and not the dryness, the joint symptoms, and the autonomic symptoms is working with an incomplete case file, through no fault of their own, simply because that information was never routed to them in the first place. And finally, back to the autonomic piece, because I think this one deserves the most attention of all five, precisely because it gets discussed the least. Autonomic symptoms are frequently the most disruptive to daily life and the least connected to a clear diagnosis. Standing up and feeling your heart race or your vision briefly gray out is often labeled as low blood pressure, dehydration, or anxiety, and sent no further than a suggestion to drink more water or manage stress. Digestive symptoms, bloating, alternating constipation and diarrhea, food sensitivities that seem to shift over time, frequently get labeled as irritable bowel syndrome and treated symptomatically without anyone asking whether an underlying autoimmune process might be driving gut dysfunction as part of a larger systemic picture. Temperature regulation problems, feeling persistently too hot or too cold regardless of the actual room temperature, often get dismissed as a normal part of aging or hormonal changes without deeper investigation. Individually, every one of these autonomic symptoms has a dozen mundane explanations. That is exactly why they get waved away so easily. But when autonomic symptoms show up in the same patient who also has systemic dryness, wave pattern fatigue, non-erosive joint pain, and neurological symptoms traveling in that same company, the mundane explanations start to look increasingly insufficient, and a more systemic, connected explanation becomes the far more reasonable working theory. I want to address something else that comes up constantly, which is the question of what to do if you bring this exact list into an appointment and still feel dismissed. This happens, and I am not going to pretend otherwise. Not every doctor is equally familiar with Sjogren's, and rheumatology in particular can have long wait times depending on where you live, which adds another layer of frustration on top of everything else. If you feel dismissed after presenting a clear, specific pattern like the one we just went through, you are allowed to ask directly for a referral to rheumatology specifically for Sjogren's antibody testing, and you are allowed to seek a second opinion if that request is brushed aside without explanation. Persistence here is not being difficult, It is appropriate self-advocacy for a disease that is well known, even in the medical literature itself, for taking years longer to diagnose than it should, primarily because of exactly the kind of fragmented, single-symptom evaluation we have been discussing this entire video. I also want to gently address the emotional weight of hearing all of this at once, because absorbing 5 separate diagnostic clues, cross-referenced against 3 other conditions, is a lot to process, especially if pieces of it mirror your own experience closely. It is completely normal to feel a mix of validation and unease at the same time. Validation because finally something explains the full pattern instead of just one piece of it, and unease because naming a possible autoimmune disease is not a small thing to sit with. Both of those feelings are allowed to exist together. Neither one cancels the other out. What matters most right now is not reaching a certain diagnosis by the end of this video. That was never the goal. The goal was giving you a framework specific enough to bring into a real appointment with a real specialist who can actually run the tests that confirm or rule this out properly. Let's talk briefly about what tends to happen after a Sjogren's diagnosis is actually confirmed, because I know some of you are wondering what comes next if this pattern does turn out to describe your own body. Management typically focuses on addressing each system involved rather than a single blanket treatment, meaning dryness gets managed with specific eye and mouth care strategies. Joint symptoms get managed with anti-inflammatory approaches tailored to how active the disease is, and in more systemic cases, broader immune-modulating treatment gets introduced under a rheumatologist's guidance. Every case looks different depending on which systems are most affected and how active the disease is at the time of diagnosis, which is exactly why an accurate, complete diagnosis matters so much in the first place. Treating dry eyes alone when the underlying cause is systemic and autoimmune leaves the rest of the pattern, the fatigue, the joint symptoms, the neurological and autonomic pieces, completely unaddressed, which is precisely why a piecemeal, single-symptom approach so often leaves patients feeling like they are managing individual complaints instead of actually treating the disease driving all of them. I think it is worth repeating one more time, because repetition genuinely helps this stick when you are trying to remember it under the stress of an actual appointment. The 5 things are systemic dryness beyond just the eyes, wave pattern inflammatory fatigue rather than constant flat exhaustion, non-erosive joint pain that persists without progressive damage on imaging, neurological symptoms that travel alongside the other clues rather than standing entirely alone, and autonomic dysfunction, the heart rate changes, the digestive chaos, the temperature regulation problems that rarely get connected to anything else. Individually explainable. Together, they tell a story that fibromyalgia, RA, and MS each explain only partially, while Sjogren's explains as a single, connected, systemic process. If even 2 or 3 of these 5 things sound like your own body story, that is enough to justify asking for antibody testing and a conversation about a possible lip biopsy. You do not need all 5 confirmed before advocating for yourself. You need enough overlap to justify a proper investigation instead of another round of the same tests that already came back inconclusive. One last thing before I let you go. If you found this useful, the most valuable next step is grabbing the symptom map, because reading it once is not the same as having it in front of you the morning of an actual appointment, when nerves and time pressure make it easy to forget half of what you meant to say. It lays out these 5 clues along with the specific tests to request by name, so you walk in prepared instead of hoping you remember everything correctly under pressure. Comment the word map and I will make sure it gets to you. And if any part of this video described your own experience with unsettling accuracy, I want you to know that recognizing your own pattern in someone else's explanation is not a small thing. It often takes years of dismissed appointments before that recognition finally happens, and the fact that it is happening here, right now, for you, means you are closer to an actual answer than you were 15 minutes ago. That is not nothing. That is the entire reason this video exists. The sicker gap closes the moment someone finally asks the right question in the right order. Today, that question got asked. What you do with the answer from here is entirely up to you, but you are no longer walking into that next appointment without a map.